Hello, and thank you all for joining us this morning for a town hall on the COVID-19 vaccines. I'm Sean Turner, Professor of Strategic Communication at Michigan State University, and I'll be your moderator for today's discussion. This is the first of what will be a series of town halls for the Michigan State University community. In each, we will address questions about the COVID-19 vaccines, from sharing information about its development process and addressing myths, to providing insights into the distribution process, both locally and throughout the state. For the next hour, we're going to hear from MSU experts about the importance of the COVID-19 vaccine, its safety and efficacy, and why leaders and people from across Michigan are deciding to get vaccinated when it's their turn. Of course, we'll also spend some time this morning answering questions and addressing your concerns about the vaccines to help you make a fully informed decision. It's important to note that our panelists, while extremely knowledgeable, will not be able to answer individualized medical questions to anyone joining us today. If you have questions related to your specific health situation, we encourage you to talk with your healthcare provider for more personalized support. And now, I'm pleased to be joined today by three guests who have wide-ranging experiences in infectious diseases, community health, and emergency management. We'll start our conversation today with MSU President Samuel Stanley, whose background in infectious diseases have helped navigate MSU through this public health crisis. He'll be followed by Dr. Deborah Furr-Holden, MSU Associate Dean for Public Health Integration, and MSU Emergency Management Coordinator, Lieutenant Dave Oslin. With that, it's now my pleasure to welcome Dr. Sam Stanley. President Stanley, thank you for joining us this morning. We're all looking forward to hearing from you. So with that, I'll go ahead and turn it over to you.
Well, thank you very much, Dr. Turner. And it's a pleasure to be here this morning and to have a chance to talk about COVID-19 vaccines. And of course, this is something of great interest to me. And in my prior life as an infectious disease specialist and researcher, I did work on vaccines. I did work on emerging infectious diseases. And so this is really, to some extent, something that I've been studying for decades. So it's wonderful for me to have the chance to talk to the community about it. I'm going to begin by showing just a few slides and really talk a little bit about where we've been, and then talk about, to me, how important the vaccine is, how it was developed, how we're going to utilize it, and how I think it'll make a difference going forward to all of us. So let me begin by sharing my screen. And anytime you do this, it's always an adventure, but we'll, hopefully it'll work well here. I'm now sharing. Excellent. Here we go. So I think one of the things I want to talk about is we've been following this outbreak for 14 months now. So this virus was first detected in China, in Wuhan, in December of 2019. And when it first came out, I thought it was going to be the third of what had been two outbreaks of coronavirus. So one was SARS-CoV-1, the second was the MERS virus, and the third coronavirus outbreak I thought would probably behave the way the first two did. It was a very severe disease, but it was contained by standard public health protocols. As we all know, COVID-19, as we call it, or SARS-CoV-2, ended up being a very different kind of outbreak. Rather than being contained by isolation, this strain ended up being far more contagious than the original SARS or MERS, and had reduced mortality, but still greatly increased transmissibility. And the outcome has been that we now are in the midst of a pandemic with more than 108 million people infected around the world, based on data by WHO, and more than 2,300,000 deaths worldwide. And those are extraordinary numbers. In the US, CDC data as of February 15th, there's more than 27 million cases we've had in the United States, and more than 482,536 deaths. In the US right now, we're seeing a decline in new cases. We were up to as many as 244,700 cases a day on January 10th. We now have lowered that number on February 13th. But we still are in the grip of the pandemic, which remains quite serious. And in Michigan, 629,000 cases, 16,108 deaths. A decline in new cases again on a rolling 7-day average from about 8,344 in December 3rd to now 1,181 on February 13th. But again, thousands of people coming down with this virus every day. And again, significant numbers of deaths. If you look at the total excess mortality in the state of Michigan and compare it to the same period As you say, look at the same 13 months, look at March of 2019 to January of 2020, and compare that mortality with March of 2020 to January of 2021, there's about 18,000 excess deaths in the state of Michigan. That's about 1 in every 500 people, essentially, excess deaths in Michigan at that rate. So it's extraordinary. The good news about the outbreak is in the bullets I have underneath each of the case numbers, and that's the vaccine. So the thing that's changing this outbreak, the thing that has the potential and will change this outbreak, has been the development of new vaccines for COVID-19. And so far, 173 million doses of vaccines have been administered as of February 15th in the world, 53 million roughly in the US. We're up to now about 1.7 million doses of vaccine per day. That's significant progress from where we were when the vaccines first became available. And in Michigan, there's been about 1.6 million doses of vaccine administered. Again, progress, and very important progress. And again, we'll talk about why that's important as we go forward in just a minute. So what are the vaccines that are available? There are 5 vaccines that right now that are being considered in the US. The 2 that are most important, and I'll focus most of my talk on today, are the Pfizer-BioNTech vaccine that's been approved for emergency use authorization by the FDA, and that's making up roughly half of the vaccine that's being administered. The other vaccine, which is a very similar kind of vaccine, and I'll talk more about how these vaccines work in a second, is the Moderna vaccine. That also has been approved by EUA, and it was approved just a few weeks after the Pfizer vaccine was approved. There's a vaccine from Johnson & Johnson. It's a different kind of vaccine, and I'll talk about how it works in a second too. And that's been up for review by the FDA in February 26. And that is a different vaccine from the others in that it's a single dose vaccine. The AstraZeneca vaccine is not up for review yet by the US. It has been approved though by the European Medicines Agency. And so it's in use in several countries around the world. That's another kind of vaccine. And then the Novavax vaccine, which is pending review in the US, but has also published preliminary data, which looks promising, is a vaccine strain that involves a recombinant protein from the virus. And I'll talk about how all those things come about in just a second. So one of the things that's been an advantage, and I'll go into more detail on this later, as we've dealt with the SARS-CoV-2 virus, is the fact that we did have the SARS-CoV-1 infection before. And so at that point in time, when that outbreak was raging, work began on developing a vaccine for SARS-CoV-1. And that work that began on SARS-CoV-1 helped set the stage for the work on SARS-CoV-2. These viruses are closely related, so it became clear very early on that some of the tactics that were used to develop a vaccine for SARS-CoV-1 could apply to SARS-CoV-2 as well. So this is important. And one of the things that was recognized in both, and as MERS as well, in all 3 of these viruses, there's a really important protein on the surface of the virus. And that's this matrix protein, the thing that looks like a golf tee right here. And this matrix protein turns out to be key to the virus's ability to bind to host cells. So it's key to the ability to bind to host cells, and also key to the virus's ability to get into host cells as well. And there's a particular part of the virus called the receptor binding domain, which is the part of the virus that actually binds to our cells and allows entry to take place. So this spike protein is really the main basis for all of the vaccines that are currently available. They're all based on the spike protein. The Novavax vaccine uses a recombinant version of the spike protein. So in other words, you clone the gene for the spike protein, you put it in another vector, and you grow up the protein. You then purify that protein, and then that's the vaccine, is that purified protein from the virus. And that's what you use as a vaccine. And that's what Novavax is based for. And that's a model we're using now. The hepatitis B vaccine is based on the same type of model of a recombinant protein from a viral protein. So this is a strategy that's worked in the past and been effective. The other one that I think is very important that I'll skip to now, and that's the Pfizer-Moderna approach. So in this case, it's a very, very different approach. We're not using any type of virus at all. We're using the RNA that actually encodes the spike protein. So this is the RNA the virus produces that actually encodes the spike protein. We're taking that RNA and we're putting some changes on the top of it that allow it to be actually recognized by our machinery to make proteins. So this viral RNA now can be made by our cell machinery to make protein. And so we're going to make a copy of this, but just that. So it's the only thing being produced. No other component of the virus is there. So this poses no risk in terms of a virus being introduced into somebody. It's just this protein that's being produced by our own cells. So this mRNA codes the spike protein or parts of the spike protein. And that is introduced in our cells in a lipid compartment. So there's a small lipid sphere, the mRNA is in there, the injection, you inject it, those lipid things can be taken up by cells, and then within our cell, that viral protein is expressed by our cellular machinery, and that prompts a very robust immune response. And this is a vaccine design, again, that's been used before. It's been used in some animal vaccines, and it's turned out, as we'll see in a second, to work extraordinarily well. The other two vaccines, both Johnson & Johnson and AstraZeneca, are vaccines that actually use other viruses to carry the spike protein into our cells. So in each case, they use what's an adenovirus vector to do this, but they use a replication incompetent vector. And what does that mean? That simply means that the virus cannot replicate. It can't grow essentially in our cells. It can enter our cells and it can express this protein, but it can't grow any further. So again, that's a lower risk vaccine, for example, than a replication competent one, where the vaccine vector can actually grow in cells. So these are the three major approaches that are being used right now. There are more than 250 vaccines being studied right now, more than 52 in human trials. So at another point in time, we could look at the whole world of what's out there in vaccine candidates, but these are the ones that are right now available for the US. And again, these RNA-based vaccines and Pfizer and Moderna are the ones that are available now. So how well did they work? This is something everybody wanted to know when they were released. They actually work extraordinarily well, and they end up being very safe. So this is the data for Pfizer and Moderna laid out. These were large clinical trials that were done. More than 42,000 people in the Pfizer-BioNTech trial, more than 30,000 in the Moderna trial. And these were representative populations. So they had elderly, they had minoritized populations represented at rates that roughly approximate the population as a whole. So that's important. So they were representative of the population from that point of view. What they found was when they vaccinated individuals with the vaccine, this is the BNT162b2, 2 doses, 21 days apart in the Pfizer study, they found 8 cases of symptomatic COVID-19 among those 21,000 people who received the vaccine. In contrast, in those individuals who received placebo, there were 162 cases of COVID. So this vaccine was 95% effective in preventing COVID-19 infection. Which is a remarkable number. That's very high, higher than probably I would have anticipated, and very, very good news. If you looked at cases of severe COVID, there was 1 case that was seen after the first dose in people who received the vaccine, 9 in people who received the placebo. So again, very high efficacy in preventing severe disease. Adverse events were similar. Essentially, severe adverse events were similar in the vaccinated group and the placebo group, which means these are things that probably weren't related actually to the vaccination at all. That's where you get that number. If you see those things are basically similar. For people who received the vaccine, pain at the injection site, fatigue, headache, fever in about 38 greater than 38, about 16% of young people and about 11% of older recipients were the major adverse events that were seen. These are generally would be considered minor. And again, given the efficacy of this vaccine, are really not major concerns in terms of reactions. After the release of the vaccine, so we now have experience from about 7 million doses that have been delivered in Israel. The doses I mentioned already, they've been delivered in the US. There have been rare cases of anaphylaxis. This is a severe allergic reaction, generally occurring within 15 minutes of vaccination. The rate is estimated to be about 5 per million doses. And so what's done now is, you know, the vaccine protocol, you may know that after you're vaccinated, they ask you to wait 15 minutes so you can be examined and looked at to make sure there's no problem with the vaccine. And that's been very effective, again, in potentially detecting. The numbers are very similar for the Moderna vaccine, and I don't want to go through it in excruciating detail. They're very similar. Symptomatic COVID-19 in 185 in the placebo group and only 11 in the mRNA group for 94% efficacy. That's statistically no different than the Pfizer vaccine. They're equally effective. There was one fatality in 30 cases with severe disease in the placebo group, no cases of severe disease in the vaccinated group. And again, serious adverse events were similar in each group, 0.6%. So post-release, again, there's been some very rare cases of anaphylaxis. with a rate of about 3 per million doses. So bottom line, safe, very, very effective vaccines. And these are the vaccines we're using right now in the US. I'm not going to go through the detail of the Johnson & Johnson, AstraZeneca, or Novavax vaccine because of time, but I'll answer questions if they come up about it later. But basically, the Johnson & Johnson single-dose vaccine is also effective. The effective rate is a little lower than was seen with the Pfizer vaccine in the one-dose protocol. But it was 100% effective in preventing COVID-19 related hospitalizations and death 28 days after vaccination. So that's very important. That means this vaccine, like the other vaccines, was highly effective in preventing severe disease, and that's very important. Adverse events are 9% over SAE, higher in placebo compared to active vaccine. No anaphylaxis was observed in that study. AstraZeneca, a somewhat lower effective rate now, again, 66.7%, but no hospitalizations in the vaccine group after the 21-day exclusion period versus 15 in the control group. And again, its efficacy got better with a longer interval between doses, a 12-week interval between doses. And for the Novavax, I think the one thing I'd point out is, because this is appropriate to things we'll discuss later, is that there was a difference in its effectiveness that was seen in individuals in South Africa who had the South African variant, which we've heard about. So in other words, they did a trial in both the United Kingdom and in South Africa, the vaccine. They found 56 cases of COVID-19 in the placebo group and 6 in the group that received the vaccine. So for 89% efficacy, that's very good. And it was more effective against the original strain than the UK variant. So that's the first time we've seen a variant difference. It was 95% effective against the regular strain of COVID-19, 85% effective against the UK variant. And in South Africa, those numbers were more dramatic. And 44,400 individuals that they vaccinated, 29 cases in placebo, 15 in the vaccine group. So the vaccine was only 60% efficacious there. And 93% of the cases they saw were of the escape variant. So this is the first indication we've had for that vaccine, which remember is a recombinant protein vaccine, that it wasn't as effective in these vaccine strains, although it still had efficacy. It just wasn't just as effective. So where are we in terms of the availability of these vaccines? Because obviously that's very important. It's one thing to show that it works in trials. It's another thing to be able to actually deliver it and vaccinate people. So Pfizer, BioNTech, and Moderna, the numbers are really similar. The US has ordered and wants delivered by August 1st, the end of July, 300 million doses of the Pfizer vaccine, and for Moderna, 300 million doses as well. So think about that for a second. That's 600 million doses essentially vaccine, which is more than enough to cover the adult population in the US for everyone to receive 2 doses of this vaccine. So just with these orders alone, assuming they're delivered, there's enough to do it. And so far each has delivered about 27 million doses of vaccine that they've promised. And their capacity, they believe, will be getting up to 6 to 9 million doses weekly, which again is going to be important in our ability to get everyone vaccinated. Johnson & Johnson right now has agreed to deliver 100 million doses of vaccine. As you may have seen in the news, the timing of when that'll be available is not completely clear. And again, this is the single dose vaccine, so that 100 million in theory would vaccinate 100 million people as opposed to 50 million doses as well as 200 million, which would be required to dose 100 million people with the Pfizer or Moderna vaccines. So total doses ordered by the US now are 1.1 billion. They've also ordered AstraZeneca 300 million and Novavax 110 million. So bottom line is we have ordered enough vaccine to vaccinate everybody in the US and more, essentially, which is important if it turned out we needed to change vaccines and maybe alter the formula for variants. That capacity might be built in now to some degree into what we've ordered. So when will people get vaccinated? So this is a study that was done by Goldman Sachs Global Investment Research to take a look at when vaccines would be available. And the US is this light blue line here. And what you can see is that if given the expected vaccination timeline, given the availability of vaccine, the hope is that up to 70% of the US population could be vaccinated by the fall. This is an older study. It doesn't take into account kind of the new vaccine orders that have put in, doesn't take into account some of the things that the Biden administration has done to increase vaccine delivery. And so I think the curve is actually shifting over this time in terms of when people might be expected to be vaccinated and when we would reach that level. And the other thing that's important is this just relates in terms of the relationship to herd immunity, is that this percentage of population just counts, of course, the people who would have been vaccinated. But there are people who have probably had COVID-19 who may have some level of natural immunity. So this might even make more people who might be at least partially protected as we move into the late summer and early fall. At this point in time, the limitations are related to vaccine availability. Once you get to this point of the curve, the vaccine limitations are more related to vaccine acceptance. So we're hopeful certainly by the end of July, that there should be adequate vaccine to vaccinate everybody. And then the problem becomes delivery and access. And so at one point in time right now, as everybody knows, supply is limiting, but as we get more and more supply, at some point in time, acceptance and delivery are going to be limiting, and we need to deal with that. So what are the challenges we face going forward? So one is efficacy against variants. I pointed out the vaccines seem to work, at least the Novavax did not work as well against the South African variant. Was still effective in reducing severe disease, that's important. But that means, at least for this vaccine and perhaps for others, we may do adjust vaccines and what's in the content. So in other words, change, for example, the structure of the recombinant protein that's in the Novavax vaccine to match the variant strains that are out there currently. That may be somewhat easier with recombinant vaccines, these ones that are using viral mRNA as the core, for example. But we have to see if that's the case or not. But we may need to adjust these vaccines in midstream. There's been generally good news with Pfizer and Moderna about variants. If you look at the data, they seem to be pretty effective against variants, certainly in vitro studies, and we'll see in real life how that holds up. But in test tubes, and as you look at measures of immunity that's produced to them, they seem to still be very effective against those variants. Then vaccine availability, supply and logistics delivery. That's a challenge. Again, we've talked about how the administration is trying to address that and really working to get as many people vaccinated as possible. And it's very important, and we'll talk more about that with Dr. Verholden, to make sure that marginalized communities are getting adequate supplies and access. One question that's really unknown is how long does protection last after this vaccine, and what's the impact on transmission? Duration of vaccination protection, that's something we'll be monitoring, and we'll be monitoring as the vaccine is used, and we just don't know. I think there's pretty good data that the vaccine is going to decrease transmission. Early data from the AstraZeneca study was consistent with that. It showed about a 63% reduction, essentially, in transmission based on positivity, based on PCR tests of positivity in individuals who've been vaccinated and not vaccinated. And the same has been seen in data from Israel using the Pfizer vaccine, where there's at least a third reduction in transmissibility so far in preliminary data associated with that vaccine, and it may be higher. I think the duration of protection is going to be better after vaccination than it is after natural infection. We see better immune responses after vaccination than after natural infection. Will boosters be required annually? Will upcoming vaccines perhaps be more effective? And in terms of duration, I think all those things are unknown at this point. And again, something we need to talk about, and it's very important, is how do we get people to take the vaccine? That's already being reflected in vaccination rates, where there's certain groups that are not taking the vaccine at high rates as others. And it can manifest as a delay to wait and see for many. And that's certainly justifiable. One can be concerned about any new vaccine that's introduced. But I think it's important that we talk about and deal with the data that we have and be data-driven in terms of what we do. And then communicate in ways that talk about how this vaccine was developed, how it works, and why it's effective. So I'll stop here and be ready to answer questions.
Well, thank you, President Stanley. That is great insight into how a vaccine works. You talked about some of the challenges facing the vaccine, to include acceptance. I think we all understand that in order for the vaccine to work across society, we need a significant number of people to actually get vaccinated, so that we sort of have the process across society where we can be safe again. So can you talk about, one, what is that magic number of people that need to be vaccinated? And two, what is your message, and how do you explain to skeptics that the vaccine is safe? For those people who might be willing but who are on the fence, what's your message to them?
So let me start with the second part of the question first, and then I'll go to the first part. I think the I understand why people would have concerns. This is, in some sense, almost miraculous that we're talking about a vaccine and we're delivering it to people. That's miraculous. If you think about the time course of how long it normally takes to develop a vaccine, but that's why people then might be skeptical about it as well. The first point I'll make is that we really did have a lot of foundational work developed when we had SARS-CoV. People may not be aware because, of course, that epidemic ended, but work continued on vaccine development for it. So people use these type of approaches and developed that the spike protein was a really great target for a vaccine. So we knew that ahead of time. They did animal studies, so they had animal models available that would allow them to test vaccines and understand for a SARS coronavirus, what are some of the parameters you could do. So all that kind of set the stage. So we weren't starting from nothing. We were starting from a foundation that we built there. And so the companies were very quickly then, they could simply substitute the sequence from SARS-CoV-2 into the SARS-CoV vectors that have been developed already, these vaccine approaches. You could simply take the sequence from SARS-CoV-2, and that was the only thing you really needed to change. You had ready-made vectors that were available. So that's the reason why this has moved so quickly. The human studies, though, were done absolutely under FDA protocol. So these were outstanding studies that were done. They had the numbers necessary to allow you to show the difference. They had the numbers necessary to identify what might be serious adverse events that were occurring at a high frequency. So when you have 40,000 individuals, 30,000 in the other trial, you're at the level where I think you can start to feel confidence in the results of these studies. So I think it's really amazing what's been done. And I feel very confident. I think scientists around the world and physicians around the world, I think almost unanimously would say these are vaccines we can have confidence in. Now, again, we're not going to stop monitoring. We're going to continue to monitor for safety. We will monitor millions of people for safety on this, and we will make sure that this vaccine continues to work and is safe. But I think both Pfizer and Moderna, I can say, I think have done their homework very well. In terms of the numbers, that's a complex question to answer, Sean, and experts kind of vary, and I've seen numbers thrown out between. So we're talking about now, what percent of the population need to get vaccinated for us to have developed this kind of herd immunity people talk about that could reduce transmission. So even some people who weren't vaccinated might be reduced risk. I've seen numbers ranging from 70 to 90%. What that number has to be. I think, again, it's complicated because as we've talked about, there's probably natural immunity in the population as well. We may already be seeing the effect of natural immunity and vaccination in some of the declining cases we're seeing right now in Michigan and other places. I think most of that is due to the interventions we made, but there may be some declines in cases right now. But I think that's something we're going to have to continue to follow and figure out. But the bottom line is the safest thing that one can do, in my opinion, is to get vaccinated. So to me, if you meet the criteria right now to be vaccinated, I would encourage you to get vaccinated. And our challenge is to make sure we're getting that message out to every community, and we have the right people speaking to communities as well about that. And that's important too. So I'll stop there, and because I know others are more expert in this area than I am, but thank you.
Well, thank you, President Stanley. I know we'll have more questions for you going forward, but I think that's a great transition to our next guest. Dr. Verholden is the Associate Dean for Public Health Integration, and she's going to talk about important considerations related to vaccine disparities and help us dispel some myths about the COVID vaccine and medical distrust in communities of color. She's also going to tell us why she is going to take advantage of the opportunity to get vaccinated when it's her turn. As we transition to Dr. Verholden, I want to remind all of our guests to submit questions in the Q&A box down at the bottom of your screen. We're getting some great questions in, and we're looking forward to answering more of those questions at the end. So with that, Dr. Verholden, thank you for joining us. I'll go ahead and turn it over to you.
Okay, great, thanks. And that was a really great foundation, President Stanley. I really appreciate it. As I talk with community, I realized we made a big mistake in even how we named and framed this. We said Operation Warp Speed, and what a lot of people heard was corner cutting or skipping steps or, quick and dirty. And so thank you, President Stanley, for clarifying for us. There was a very rigorous process in place. And the great thing about innovations in medicine and science is through mRNA vaccine technology, we are now able to take the code, the genetic code of a vaccine, and within 2 weeks, make a candidate vaccine. I mean, this is going to transform how we deliver health and healthcare and vaccination. So there were no steps that were skipped, but I can understand why people may feel that way. So a couple of points that I want to touch on. The myths and misinformation I know are a big problem. We know this. I think people have just enough information to be dangerous to themselves right now because, we've all sort of learned a lot about vaccines and viruses and spike proteins, things that we'd never heard about before. And then I think we also had some gaps in information. And so I want to answer one specific question and give you a sort of bigger picture way of thinking about how and where to get trusted and credible information. So the first thing I'll say is there's no one sole source. I think the CDC is great. I have many colleagues who work at the CDC. I told people all during this pandemic, the CDC is filled with some of the nation's greatest scientists and clinician scientists and researchers and epidemiologists, et cetera. And I think we've seen with our new administration, they've really gotten their mojo back, and they are only one source of information. So there was a specific question posed about the safety of the vaccine during pregnancy. And I think that's a really great question because I myself had gotten news, I'm going to be a grandma. My oldest daughter is pregnant. And so we really had to roll up our sleeves and look and figure out, what was going to be the decision that she would make. And she's actually also a frontline healthcare worker. She works in a hospital as a patient advocate. And so we went to the trusted, credible source for pregnant and postpartum women, the American College of Obstetrics and Gynecology. These are the types of groups, these professional societies and organizations who have rolled up their sleeves to really do the work and look more deeply when it comes to specialized populations. As an African American, we know that sickle cell trait and sickle cell disease is overrepresented in the African American community. The National Medical Association did a deeper dive into the data that came out of the FDA, and they're working and looking at the data as we roll out the vaccine and we get greater numbers of people who have sickle cell trait and sickle cell disease. So I really encourage people to not just go with some of the usual suspects. Do not get your information from the newspaper. We have great trusted sources of credible information. Included in that are our local health departments, especially as it relates to vaccines. That's a very, very important resource. Why? Because vaccines are actually being rolled out at the local level. So if you want to know what's happening, your local health department is a trusted, incredible place to get that information. Going back to the point that people have enough information to be dangerous, one of the questions that my own daughter raised, and I want to touch on this just because somebody posed this in advance, is she said, well, Mom, if you can't get the vaccine under 16, how is that vaccine okay for my fetus? And I thought that's a really great question. And what we did is we went to the ACOG website and we looked at what their recommendation was. And they are very clear. They've looked at the data as it relates to pregnant and lactating women. And their recommendation was that that group, when they're eligible, not be excluded from the opportunity for vaccination because they saw no indication that it would pose harm to the mother, that it would pose harm to female fertility, or that it would pose harm to the fetus. So again, I really encourage people, get that trusted, credible information. Another gap that I'd like to speak on that really points to this issue around equity is we've seen now the critical importance of the need for a medical home. If you didn't have a medical home coming into this pandemic, I really encourage people, take that seriously, not just you, but for your loved ones and the people in your community and the people that you come in contact with. I always tell people your medical provider is not the person in charge of your health and wellness, you are, but they're a critical player on your health team. And so if you don't have a healthcare provider, I'm encouraging people, if you lack insurance, reach out to your local health plan. There are local health plans who are charged with the task of making sure that everybody in their community has access to health coverage. If you don't have health coverage, if you fall in that weird spot where you make a little too much to qualify for, Medicaid or other supports and not quite enough to be able to afford it out of pocket, please reach out to your local federally qualified health center. You might say, well, I'm an MSU employee, I have health insurance, but you may have others in your life who don't have that luxury or that benefit. The federally qualified health centers, the FQHCs, are charged. They are the stake in the ground for ensuring that everybody in the community has access to a medical provider. On the issue of equity, we have major, major gaps in our system. We saw huge breakdowns in both distribution and the data infrastructures that are needed for us to answer the question, are we not only getting the vaccine to community fairly and equitably, but are we also getting into people's arms fairly and equitably? And I sit on a federal partners call. There's about 13 federal agencies who, again, have their sleeves rolled up and are really doing the work to try to backfill those gaps and make sure that we're doing a good job and being a good steward of the vaccine. I consider the vaccine a dose of hope. And I personally believe hope is something that should be fairly and equitably distributed to all people. So just know that we know we have problems. The state of Michigan is the only state that I know of that closed the racial disparity in COVID cases and deaths. We did that by July. In September, we declared it a victory because that gap remained closed and it stays closed. We've now got to roll up our sleeves and do the same work around vaccine administration and distribution. One of the problems that we have is there actually right now is no federal mandate for that. And I am on a push to mandate equity. And when I say that, what I mean is some requirement that who actually gets the vaccine administered, injected into their arm, very closely mirrors the population, the community where that vaccine is being administered. And that goes beyond racial equity. We all have elderly loved ones, and we've watched people jump the line and get the vaccine ahead of them. We have people in our families with pre-existing health conditions that predispose them to a bad outcome from COVID. So when I say equity, I just mean fairness, fairness for all people. And I will tell you, our federal partners are fired up and figuring out how we can get that push in place to get our states to really make that a value and something that's at the forefront of how we're getting this vaccine out to people. I know there might be a lot of confusion for people. You say, my numbers come up. I'm in category 1B. I'm 65, I'm 66. I'm a teacher, and now they've been brought online. And there, unfortunately, again, a gap in our system and how things are being done is vaccines are not going to states through one single source. Some are coming to the states are distributing it through county health departments and through large hospitals. And the federal government is also doing direct distribution to pharmacies and big box stores and other places. So I do realize that it can be confusing. And you'll also have the opportunity, many of you, to get vaccinated through the university. So here's my recommendation for people. You have to stay on your toes and you have to stay informed. Again, our local health departments, I think, are doing the best job that they can at making sure that they get information, even for vaccine that's not in their hands, that's not in their control, that were distributed directly to pharmacies without their knowledge or their input. So if you sign up, if you're eligible, I encourage people to sign up. And if you sign up on multiple lists, you sign up through your health department, you sign up through a local pharmacy. When you get your first dose of vaccine, I'm asking people to be a good steward of the opportunity and go back to the second list and cancel that appointment. Don't do it till you get that first dose, but please be a good steward of the opportunity and know that we're also working hard to get the data infrastructure in place so that we don't have so much duplication of effort and so much burden on people and already overburdened organizations to ensure equity in distribution and administration. The last thing that I'd like to say is the choice of whether or not to get the vaccine is yours. I don't tell people to get the vaccine. What I tell people is this: if you don't grapple with it right now, if you don't do the work and get all the information and get all of your questions answered, and we saw this happen, your number will come up. You might be a no or a no for now. You won't lose your right to be in line, but you may lose your place in line. I live in Genesee County. We have a 57,000 person wait list right now. I got that number from our health officer yesterday, and the list grows by 2,000 people a day. They estimate that about a third of those people are actually in category 1A, and they were a no when their number came up. They had a change of heart, and now there are 57,000 people potentially back in line. So I really encourage people, do the work, grapple now. We want to get to herd immunity. The way to get to herd immunity is through prevention. I'm an epidemiologist by training. I heart public health. It's like the thing that wakes me up and lights me up every day. Herd immunity is not about allowing a significant proportion of our population to get sick. It's about preventing them from getting sick in the first place. So as you grapple with the decision about whether or not to get the vaccine, harken back to President Stanley's example. This vaccine is giving you a very small piece of that virus, that spike protein, which if the whole molecule gets in your body, that spike protein is like a key. It unlocks your cell and it lets the whole viral molecule in. This spike protein is turning the key. Your body's building antibodies to stop it from ever being able to get in. If you have concerns about getting this little piece of the virus that's not going to actually get you sick, that's going to help your body mount a credible defense if you actually get exposed to the virus. I ask you to weigh that against what happens if you actually get the virus. So please let your concerns be balanced by you'd rather deal with a sore arm and maybe a fever or chills or a headache for a few days than deal with the consequences of being infected with this vaccine. I'm going to stop right there and hand it over to Dave. Thank you so much.
Thank you, Dr. Verholden. Before we hand it over to Dave, just a quick question for you. One of the things that came through clearly in your presentation is just that it's a very complex system right now for getting people vaccinated. Lots of questions about when and where and how and who. I wonder if you could just address the issue of for people in phase 2, that sort of largest group of people who need to be vaccinated. Would it not be simpler to simply have a system in which people are vaccinated by age? Once we get beyond those people who are the highest priority, if you're between the ages of 50 and 60, then you go and you can verify and get vaccinated. And then we move to 40 to 50 and so on. Wouldn't that be the simplest and most efficient way to get the largest number of people vaccinated?
Absolutely. And here's what I tell people when it comes to COVID. Be prepared for a game changer every 2 or 3 days. Right? Remember, science is not about we've got it all figured out. This is the truth. At one point, they said the world was flat. Thank God somebody ventured beyond that point, and we, have learned a lot about how our world works. We're learning a lot about how to do the rollout, distribution, and administration of this vaccine. It would not surprise me if by the time we get to phase 2, we see better systems for ensuring those who need it the most and those who are at risk for the worst outcomes move higher up in the priority chain. So I just ask everybody, be patient. That's why it's also so important for people to do that work now, so that when your number does come up, you don't lose your place in line. But I would venture to guess change is coming on that one.
Thank you, Dr. Verholden. Great perspective on the vaccine. I want to turn now to our final panelist, Emergency Management Coordinator, Lieutenant Dave Oslin. Lieutenant Oslin is going to discuss where we are in the vaccination process locally and across the state. He'll also talk about vaccine distribution at the MSU Pavilion and the process that MSU employees are being asked to follow to get vaccinated. So with that, Lieutenant Oslin, thank you for joining us. I'll turn it over to you.
Thank you, Dr. Turner. And Dr. Verholden, thank you very much. Your ending there really ties into what I want to talk about, because it's that change piece that has been, as we started this process 365 days ago, I sat in a meeting talking specifically about COVID and the impact to the international community on campus and our study abroad program. So for 365 days, we've been living this, and we've been dealing with change in what we know about the virus, how we respond to the virus. The big thing, and I'll talk logistically about Ingham County because that's what I'm most familiar with. MSU has been the host site for the Ingham County Health Department mass vaccination clinic. And I say mass, right now we're averaging about 1,000 doses a day, 4 days a week. The incredible part is that we can do that in about 8 hours a day. So as vaccine becomes available and we make that shift to getting 8,000 doses per week, we can quickly dose 2,000 people a day. We just expand that time frame. And you brought up, Dr. Verholden brought up the idea and the concept of registration processes. That's the one consistent thing across the state of Michigan. Whether you're in Ingham County, Clinton County, you live in the UP, vaccination sites have processes. I know Meijer, as one of the big box stores, they have a registration process. You get on their registration list, and when your number comes up and they have vaccine available, they make contact with you on scheduling an appointment. It's the same thing here in Ingham County. Our registration list is, I think, about 50,000 people long as well. But the health department will then go through that list and pick out who meets the current criteria. And right now that criteria in simplest terms is 65 years of age and older. Once you meet that criteria, or the criteria comes down to your group, the health department sends you directly an email with a link to scheduling your appointment. The one that's one of the big things that we have to remember through this process is the local health department or the local pharmacy that's running that process should be the one making direct contact with you to schedule your appointment to come in and get vaccinated. The process that we have set up at the pavilion is a drive-through clinic. We have 7 lanes set up. We can bring about 70 to 75 cars in each half-hour time frame, and we have vaccination teams that come through, vaccinate you. We write the time on your window so we know when you got your dose. And as Dr. Stanley said earlier, that 15-minute time frame for observation is key in this whole process. We use the pavilion. It allows us to have that observation time indoors. When a vehicle comes in, we ask them to turn their engine off, lower their window. The temperature inside the building is 60 to 65 degrees, so it's comfortable for you to sit and wait through your observation time. Each lane has a person that's designated to be that observer, and they walk through and they talk to you and they make sure that you're feeling okay, you don't have any adverse reactions, and they watch that time frame to release you when we bring the next group in. So that's how our 8-hour day runs down at the pavilion site. Right now in the state of Michigan, there are a couple of options for that process. Really what you're looking at is you have the ability to sign up in the area where you work and the area where you live. So if I work in East Lansing, I live in DeWitt, I can register in both Ingham County and Clinton County. That does not preclude me from signing up for any of the pharmacies that start a process as well. But it's all going to come down to what category we're currently working in. Again, 65 in Michigan is kind of that key age. The Ingham County Health Department, I think, has done a fantastic job, and Linda Vale has done a really good job of maintaining that scheduling process as we go through this, but also then working with employers to make sure that she's bringing in the right groups when she needs to. I know for our MSU staff, one of the big questions that we had early in this was, when's it going to be my turn? When do I get the ability to do it? We're working with the county to make sure that as different criteria or different frontline workers within the university are part of that next category, that we're ahead of the game a little bit and we get them into that registration process, and then the county can pull their names out to get them the scheduling link for scheduling their next appointment. One of the things that I wanted to touch on, and Dr. Verholden did a little bit, is patience. Patience has been part of this since the start, and it is continuing to be a part of it. The two things to remember are, depending on when you register, when you get onto that county website or pharmacy website, your ability is going to be based on the availability of vaccine in your area. It may be weeks before you get contacted from an agency that you can schedule your appointment, and you may be scheduled a week or two out. But you have to be part of that process, and you have to be patient with it. In the past year, all response related to this crisis and the virus, we've changed on, and Dr. Verholden said a couple of days. We've changed daily, we've changed weekly. It all depends on where we are in the process. And a lot of it comes back to the science and the knowledge that we learn about this virus as we go through this. I too want to express my feelings of the importance of this vaccine. This is the next step in our response. We've learned that we have to be active in every step. The vaccine isn't going to bring it to an immediate end. We're going to need to continue to wear masks, be socially distanced, do the personal hygiene things that we've been doing for the last year. The vaccine is the next layer in the defense against COVID, and everyone's going to be a little bit safer as we work through this process. That's the end, Sean.
Thanks, Lieutenant Oslin. I appreciate that. You touched on the fact that that for MSU employees, that there'll be more information regarding when they can get vaccinated. I wonder if you can drill down on that just a little bit. For all the MSU employees out there listening, Will there be information pushed directly to them to notify them that they are now eligible to be vaccinated? Or will there be some place where employees will need to go and check regularly to find out when it's their turn in line? Can you talk a little bit more about how that process will work?
So very recently, and within the last week or so, conversations with the Ingham County Health Department, we've talked about kind of what that next step is. And the county health officer is in close conversations with the state of Michigan on next categories that may open up. We've taken the approach that we will work with the county health department to, through MSU, make sure that that registration link makes it to the next group or groups that are going to be opening up. So as we change, if we change to an age category, we can adopt that through the HR department and get those lists of who may fit that next category. If we open it up to, and I'm going to take a minute to look at food and agricultural workers, which may be that next group, who within the university may fit that, we'll make sure that that registration link gets out to those groups. If they've already registered, great. We're going to work with the county health department to try and help pull those names out of their registration list and get them into that scheduling piece. And again, that's a change that has happened in just the last couple of weeks. We've been at this vaccination process at the pavilion since December 21st, and everything changes. And that's the recent update.
Thank you. I want to thank all of our participants. We've got some really great questions coming in through the chat function, and I want to go ahead and turn to our panelists now to try to get some of those questions answered. We're going to dive right in. President Stanley, a lot of people are wondering why Michigan higher education, our educators, are not included in the higher prioritization group for COVID vaccines. Can you talk a little bit about why professors and educators at this level are not being included at this point?
So it's a question that I get a lot, and I've talked about before. I think it was a decision made by the state of Michigan. If you look at the original CDC recommendations on vaccination, there is more discussion, or actually the special panel that did the immunization recommendations. There was emphasis on K through 12 and not so much on higher education. I've said that I'm not sure I see the difference in potential risk between those groups. I think if you're deciding that people in K through 12 have a risk that's associated with teaching, you probably would argue that the risk is probably similar for people who are in higher education. And in fact, if you look at disease rates within the populations that are college age populations, probably have a higher prevalence of COVID-19 infection in general than do kids. So if you're going to make that distinction and say that people who are teaching should be vaccinated, then I can't see why higher education wouldn't fall into that category as well, just logically. And that's the point I've made to the state before, that if you're going to do this, and again, I'm with Dr. Verholden, I think there's lots of ways to do this. And I think age still remains a very powerful one, and comorbidities to me remain the most powerful one. So if I were in charge, so I'll just be honest, if I were in charge of things, that's how I would stratify. I think, but that I'm not in charge of it. And so I've certainly argued for that, but so far there hasn't been a willingness to change that in the state. There are some other states where higher ed has been bumped up, but not in Michigan.
Understand. Thank you for that feedback. Dr. Verholden, I'd like to go to you. Can you address the issue of whether or not vaccinated people can still become infected with the coronavirus, and whether or not they can spread the virus once they've been vaccinated?
Great. So the thing that we know, is the vaccine is super great at preventing severe illness. So if you were to be exposed and you're vaccinated, it's very good at preventing severe illness. Think about it. This virus is brought into the body through the respiratory tract, through your mouth, through your nose, and possibly even through your eyes. So there is a remote possibility that you could be out, you could inhale virus, and you could exhale it. And even though you're vaccinated, you could still pass it on to somebody else. That's a very small possibility, but it's possible. And there will be people for whom they will have been vaccinated. And there's a little bit of a complexity because the full effect of the vaccine happens weeks after you've gotten the first, and then the full 94, 95% happens, 2 to 3 weeks, depending on which one you got, after you get the second dose. So let's just pretend we're in the best case scenario. You've gotten your first dose, depending on which one you got it in the right time frame window, You got the second dose, you're 3 weeks out, so you have the full benefit of the vaccine. There will be some very small percentage of people who will actually still get the virus. And if you get the virus, they still may have the potential to spread the virus. But that likelihood goes way, way, way down relative to if you were not vaccinated. And more importantly, it gives you the tremendous benefit of avoiding these very negative outcomes that we've seen people have. And there's something worse, not worse than, but also really bad short of death. And we're learning now that even people who were asymptomatic or had very few symptoms, we're starting to see these wonky long-term effects that people are dealing with. So it goes back to the point that I make, that you would much rather get the vaccine than the virus. So it's an imperfect but important layer of protection. Imperfect, but critically important.
Thank you, Dr. Verholden. I want to come back to you, but before we do, I want to go to Lieutenant Oslin. Lieutenant Oslin, lots of questions about where people should register for the vaccine. I wonder if you could spend just a few seconds giving some very practical advice for people who are sitting at home right now saying, I want to register right now. What should they do?
As Dr. Verholden said, the best source is the local county health department. So your place of residency, your place of work, those are the two, your county health departments. If you register there now, those give you the best availability. As other categories open up, definitely if, Meijer has a registration process, Walgreens, CVS, those large pharmacies, those are places to register as well. And as Dr. Verholden said in her presentation, register as many times as you can. If you live in 2 counties, register in both counties. The important piece to remember though is once you have that first dose, if they schedule you for your second dose, cancel any other appointments that you have. If you can pull your name out of that registration process, do that. What that does then is if you've already scheduled an appointment, it opens up a slot, they can put somebody else in that slot. The other side of that is as planners at the county level talk about how many vaccine doses do I need on Monday? How many vaccine doses do I need on Tuesday? As slots open up, if they don't fill them, they know not to pull the vaccine out to account for that dose. That's been one of the pieces as we've worked through this process is, we're eight weeks into this. The process is a little smoother. At the end of the day, there are less doses that we have to try and figure out how to disperse. Some places have great protocols in place for that and some don't. The ones that don't end up then either wasting the vaccine or struggling to get it pushed out, and it just puts more stress on the system. So once you've got your first dose, cancel any of those other appointments that you may have, except for that second dose with that original site.
Thank you, Lieutenant Oslin. President Stanley, you understand better than anyone how infectious diseases work. So I want to talk for a minute about behavior for people who have been vaccinated. Once someone has been vaccinated, can you touch on the degree to which they can or they should or should not stop social distancing, stop wearing a mask? What kind of behavior should people enact once they have been vaccinated in order to continue to keep people around them safe?
So that's a great question. And I think it's probably one where the answer may evolve over time as more and more people get vaccinated, will change kind of the constraints that we're under. So I want to be optimistic in thinking about this. But in the immediate future, as Dr. Verholden, illustrated so well, there still is risk associated with people who've been vaccinated and their ability to transmit and actually contract disease as well. And again, we know that it's going to be much reduced risk. We think probably in both directions, but it's not going to be zero. And so, for the protection of others as well as yourself, I think I would continue. I don't think you should continue to wear a mask. You should continue to do social distancing, and that's where we're going to be finding ourselves for the foreseeable future. But I think there will come a time when we reach a particular vaccination level and when we reach a particular level of immunity within the population, that we'll be able to change those protocols. Now, I for one, may continue wearing a mask in the winter just because it's knocked seasonal influenza, flu down so much that maybe it's a good idea for us to mask in the wintertime just because of that, as they do in other countries. That I may start thinking about doing that. I have a great Spartan mask, and I don't mind representing frequently about it. But in general, for now, we don't change these protocols. We're going to continue these protocols for now. And I think it's something we're thinking about as we plan for the fall, is what will the levels be, and what can we do or not do. Everybody wants a return to normalcy. This vaccine is the pathway. This is the pathway to it, but we also need to continue to try and reduce transmission. And that's really important, particularly as we deal with these variants as well. The less transmission they have, the more we keep virus population down, the fewer variants we're going to have to deal with going forward. So it's really important, I think, that we continue what we're doing. As people are getting vaccinated, we continue to wear masks, continue to social distance, and large gatherings, all those kind of things should continue.
Yeah, thank you, President Stanley. If I can stick with you for just one other question, just because we're seeing a lot of concern about just the idea that these vaccines were developed on a timeline that was much faster than we've seen in the past. And while there's lots of initial data to indicate that they are safe, and certainly you've made a good case for that today, people are concerned about what we don't know with regard to the longer term effect that the viruses, that the vaccines could potentially have. So can you talk for a minute about what gives you confidence that while the vaccines may be safe today, that there won't be some negative effect down the road?
Well, I think, again, as my colleague said, if you take a look at what the Moderna and Pfizer vaccines are, they're really a small piece of viral RNA that has no ability to propagate. So you can't make a virus out of it. Some of the vaccines we have, people have some concern sometimes because we're using an attenuated virus. It's a virus that we've altered in some way so it no longer causes disease, but still can infect. We have these replication deficient viruses, which again, I think are going to be perfectly safe, but do represent a virus being introduced, although it's not the SARS-CoV-2 virus, it's an adenovirus or other viruses. There's lots of ways to make a vaccine. This is a novel way to make a vaccine, and one in which, again, our own cells are making the protein, and not a viral cell. And I think for that reason, it's a very, very safe thing. So what you're really talking about is, if you look at long-term safety of vaccines like the measles vaccine, the mumps vaccines, all the vaccines we have our children get, these are extraordinarily effective and don't have long-term risks generally associated with them at all. So I say this vaccine, in terms of how it's constructed, poses even less of a theoretical risk than those do. So I feel very comfortable about its safety and the long-term prospects. And again, as Dr. Verholden said so eloquently, what would you rather have? You would rather, be confronted by this vaccine with, whatever concern you have about it, or the virus itself, which, as we've talked about, has, had extraordinary impact on morbidity and mortality in the country. We have lost, nearly now 500,000 Americans have died from this virus. It's an extraordinary impact on us, and this is a way in which we can slow it down. So I think everybody should always be a little skeptical. You should always question. You should talk to your health professional. Do your homework. Talk to your health professional about this issue. Don't have to just take my word for it. But I think, again, you're going to see pretty much unanimity in the medical field about the safety and efficacy of these vaccines, the Moderna and Pfizer, as we're talking.
Thank you, President Stanley. We're going to have one more question during the session today, and I'll remind everyone that we are going to continue to work to answer your questions. So just because we don't get it answered in the town hall today doesn't mean that we won't work to answer those questions. Dr. Verholden, are we going to get vaccines here at MSU to be distributed?
I don't know that I'm the best person to answer that question. I think that's probably a Lieutenant Olson question, Osling question.
All right, well, we'll direct that to Lieutenant Austin. What do you think?
President Stanley.
Yeah. Let me jump in really quickly and just say that we have put in a request to Ingham County and to the state that we become a center essentially that could distribute vaccines, because again, we want to, because of the pavilion and other barriers, we believe we have the capability to help with this process, and we'd like to accelerate it where we can. Hasn't been granted yet, as Dr. Verholden said at the beginning. Right now it's going to hospitals and health systems, it's going to local county health, and there is some direct distribution to pharmacies like Myers and CVS and Walgreens. That's where it's going right now. But we put in for it. We would like to be able to help do this. We have the freezers and other things for Pfizer, so we have the capacity, we believe. And we want to see a country where we're getting over 3 million doses a day delivered. We've got to get there if we want to reach these goals we've talked about. So any thing we can do to help get there, we'd love to help with that.
Great. Well,
John, just to add on to President Stanley's
Go ahead,
comments, not only the request, but we have the plans. We have some plans in place and have been worked through a couple of different models. So when vaccine is available, we could stand up something in a couple of days. So yeah, the effort is there.
Great. That'll be encouraging news to all of our listeners today. President Stanley, Dr. Verholden, Lieutenant Oslin, you've each provided us with some really important information and insights into the COVID-19 vaccines. I want to thank each of you for joining us today. And to you, our employees, thank you for tuning in as well. I know we weren't able to get to all of your questions today in the limited time we had, but over the next week, we're going to continue to address some of the commonly asked questions we received today. And we'll continue to work here at the university on the coronavirus website to make sure that we update that information for you as often as possible. Please continue to visit msu.edu/coronavirus for the latest information on our next town hall, the COVID-19 vaccines and the university's response to this ongoing pandemic. Again, thank you all for joining us. Have a good day.